that my cue?
Yes,
Sure. Looks
yes,
like
Corey, go ahead.
Okay. Good morning. Welcome to today's webinar. My name is Corey Robinson Rosenberg from JFK Partners at the University of Colorado School of Medicine. JFK Partners, including the CDC-funded Autism Case Control Study to explore early development, and the Colorado Title V MCH program, collaboratively present a quarterly educational series to address the current Colorado Title V MCH priorities and emerging issues. This series is intended to expand the capacity of the maternal child health workforce and related systems to better serve infants, children, youth, including those with special health care needs and their families. Today's topic is bullying and autism, frequency, consequences, and interventions. Please feel free to type questions or comments in the chat box at any time. Captioning and Spanish interpretation may be accessed using the Zoom functions at the bottom of your screen. We ask that you please keep your microphone muted so that we do not hear background noise. We are recording today's event and will archive it on the JFK Partners website, along with the other webinars in this series. We will also post the handouts for today, which you are welcome to print or save for future reference. Following the webinar, you will receive a link requesting an evaluation. You may request a certificate of attendance in the evaluation. Today's speakers are Carolyn DiGiuseppe and Christy Bartholomei. Dr. Carolyn DiGiuseppe is a professor of epidemiology in the Colorado School of Public Health and professor of pediatrics in the School of Medicine at the University of Colorado Anschutz Medical Campus. She received her medical degree from the University of Virginia, Master of Public Health from the University of Washington, and PhD from University College London. She completed her pediatric training at Seattle Children's Hospital. Dr. DiGiuseppe has published over 200 journal articles, book chapters, technical reports, and scholarly reviews, many on the causes and characteristics of autism, with a particular focus on both unintentional and intentional injuries experienced by autistic children and adults. She serves as principal investigator for the study to explore development, SEED, follow-up study of autistic children, adolescents, and young adults, and is currently collaborating with investigators at Columbia University to examine mortality in autism across the lifespan. Christy Bartholomei is a graduate research assistant in the Department of Epidemiology at the Colorado School of Public Health, University of Colorado Anschutz Medical Campus. She holds a Bachelor of Science in Neuroscience and Molecular Biology from the University of Colorado Boulder and a Master of Epidemiology and Clinical Research from Stanford University. Ms. Bartholomei has authored numerous peer-reviewed publications focusing on autism-related disorders, with a particular emphasis on the unique experience of girls. In addition to her research, she is committed to youth science and education and volunteers her time to support STEM outreach initiatives. She is currently collaborating with SEED researchers at Johns Hopkins University to investigate the genetic factors influencing independence in autistic individuals. We welcome both of our presenters today and look forward to most engaging presentations. Thank you.
Thank you so much for that wonderful introduction. Just a couple notes. Ms. Bartholomei and I will speak sequentially. I'll give my entire presentation and then she will give her presentation. And then at the end, we will respond to questions for either of us or both. So please do put any questions into the chat. I won't be able to see them as I'm speaking, but we will be going through those at the end, and you're welcome to share your comments and thoughts. All right. So I'm going to attempt to share my screen, which I had a little trouble with earlier, but we'll see how it goes. Okay, I think it's good. All right, so to, the first part of this presentation is going to be about bullying victimization and engagement in bullying in autistic adolescents. And I do want to acknowledge my collaborators on this analysis. So I wanted to start by talking about what is bullying. And bullying involves intentional, repeated aggressive behavior towards another person. So a single, children getting into a fight on the playground, a single episode of someone being teased is not typically considered bullying. It needs to be repeated, but it is intentional aggressive behavior towards another person. And it involves also a power imbalance that makes it harder for the victim to defend themselves. So kids who bully others use their power to control or harm others. And that could be their power in terms of their physical strength. They're bigger than someone else and they can therefore bully them. It can also be their social power. A teenager who's more popular may bully or exclude others. So intentional, repeated aggressive behavior that involves a power imbalance. Bullying can take a lot of different forms. There's verbal bullying, which is things like name calling and insults and threats. There's physical bullying, which would be hitting and kicking and shoving. Social bullying is bullying that involves intentionally excluding others or gossiping about others or spreading rumors about others, again, with the intention to harm. And then cyberbullying, and then bullying would be things like stealing or damaging someone's property. Bullying can take place face-to-face or online. We are certainly seeing an increase in online or cyberbullying, and that really is using some kind of electronic means, usually social media of some kind, but it could be email, to threaten or harass or exclude someone else. And the reason we care about bullying is because it has important potential short and long-term consequences. Obviously, immediately there can be physical injury from the physical bullying or social and emotional distress from, for example, social or verbal bullying. Children who are bullied often themselves develop aggressive behavior. They may have sleep difficulties and academic problems. And then in the longer term, there are consequences like substance use, depression, and anxiety. You'll hear a little bit more about consequences of bullying in the session later today. So bullying in autism is common. Nearly half of autistic people report having been bullied. It's about 3 times as common in autistic people as their peers without autism. Some of that may be due to challenges in social communication and interaction. It could be some individuals with autism have fewer friendships, and friendships can be protective against bullying. Could be other characteristics associated with autism, for example, repetitive behaviors that may make them a target for bullying. So a lot of different possible reasons for that. While there's been quite a few studies looking at how frequently autistic individuals are bullied, there's been not very much literature on different types of victimization and whether some types are more common than others for autistic teens. And then some of that is conflicting. And also there's not very much information on how much teens with autism themselves engage in bullying. And that's important in part because people who are bullied are also more likely to bully others. So the questions I'm asking in this analysis are, among adolescents who were identified in early childhood as having autism, how often have they been bullied, in what ways? How often have they themselves engaged in bullying other children? And how does that compare to adolescents from the general population? So I want to briefly outline how this study was designed. So I want to first give you a little overview about the SEED study, which Dr. Robinson Rosenberg briefly introduced. So SEED is a study that has been going on for quite a long time. And the first enrollment took place back in 2007. And the enrollment of young children and evaluating them for characteristics of autism and risk factors for autism took place in 3 phases: SEED 1, SEED 2, and SEED 3. In those phases, we enrolled children between the ages of 2 and 5, and those children were screened and examined and classified as having autism or not having autism. A sample of those children, the ones who were enrolled in the first phase of SEED, SEED 1, their families were recontacted in between 2018 and 2021 when the teens were about 12 to 16 years of age, and that was SEED teen. And then there's some other aspects of SEED that I'm not going to go into today. So for this analysis, I'm including children who were enrolled in SEED 1 and then had follow-up in SEED teen. And the autism group for this analysis is teens who had been identified back in SEED 1 as having autism. So they were classified as having autism in SEED 1 based on standardized instruments like the ADOS and the ADIR. And then the comparison group is teens who were enrolled in SEED 1, who were from the general population and did not have autism in early childhood. So that's our comparison groups. The questions about bullying come from the SEED teen survey. So the parents of the teens were surveyed and they were asked some questions relevant to bullying. And the first question they asked was, has this child ever been bullied by another child? And for each of these questions, the parent could answer yes, no, or don't know. Only a few parents answered don't know. Those are not included in this analysis. So we're including those who had an answer. So if they responded yes to has this child ever been bullied by another child, we then asked during the past 12 months, have they been bullied by another child? And then if that answer was yes, they were asked about some specific types of bullying behavior. And then we then grouped those into those 4 types of bullying I talked about earlier: physical, like being hit or slapped; verbal, being teased or picked on; social, being ignored or excluded; and then cyber, which would be any kind of electronic means for doing something hurtful to another child. And then the third question we asked is, has this child ever bullied another child? So I think there's a few key points I just wanted to mention about these bullying questions before I move on. So we did not define bullying. We did not say, has this child ever been bullied by another child? By that, I mean intentional, repeated behavior that involves a power imbalance. And it is possible that parents of those classified with autism responded differently than those who did not. Secondly, given their social challenges, I think autistic teens would typically have less power in their peer relationships. So again, when a parent reports that their autistic teenager bullied another child, it still has a question of whether that's really bullying going on or whether it's just aggressive behavior, which can co-occur with autism. So again, that also should be kept in mind. And the third thing is, I think obvious to everyone, is that parents don't always know what their teens are doing or what's happening to them. And so, we may be even underestimating the bullying that the teenagers in both groups are experiencing because parents may simply not know whether or not their teenagers being bullied. So these are sort of what the parents do know about and report, but obviously there could be additional bullying going on. All right, so let's talk about the results. So who is included in this study? We had 174 teens with autism, classified with autism in early childhood, 296 teens classified without autism. Their average age in this sample is just under 15 years. The majority were male. And almost all of them, more than 80%, were in a regular classroom some of the time or all of the time. And then the remainder being in special education or homeschooled or not in school. Among the group that was bullied in the past 12 months, and this includes both teens classified with autism and without autism, looking at that group overall, those who were bullied were more often male. So boys were more likely to have been bullied than girls. They were slightly younger at the time of the survey than those who had not been bullied, but just really by a few months. But otherwise, we didn't really see a lot of differences between teens who had been bullied in the past 12 months versus those who hadn't. For example, in terms of the mom's education or the household income or the type of classroom. So that didn't seem to have a lot of impact on whether or not a child was bullied. All right, so this is the results for whether a child had been bullied in the past 12 months, comparing teens who had been classified as having autism or not having autism in early childhood. And the black or dark gray bars represent teens with autism, and the teal represents teens without autism. And you can see that that teens with autism, classified with autism in early childhood, were much more likely, had much higher frequency of having been bullied, about 30% versus about 12% in the teens without autism. Almost all the teens who had been bullied at all had been verbally bullied. You can see that the numbers are similar. Social bullying is also more common in teens with autism, and physical bullying is also more common in teens with autism. In cyberbullying, however, it went in the other direction. Cyberbullying was pretty uncommon in teens with autism, and it was also not particularly commonly reported by parents of teens without autism. Again, recognizing parents may not always be aware of what's happening with their child. So we did an analysis where we took into account the difference in sex distribution between children with autism and teens with autism and teens without autism. And after taking that into account, as well as a couple other things, we found that autistic teens were about twice as likely to experience any bullying, verbal bullying, and physical bullying, and 3 times as likely to experience social bullying compared to teens without autism. And in contrast, they were about half as likely to experience cyberbullying. So they were less likely to experience cyberbullying, although really that difference was pretty small and not very important, but definitely quite a bit more likely to experience the others. And this is really talking about recent bullying. In terms of ever having experienced bullying, the frequency is actually a little bit closer in this case. Quite a lot of teens without autism, their parents reported that they had ever experienced bullying, about 40%, but it was still higher at 60% in teens with autism. We also found that parents of teens with autism were more likely to report, more frequently reported that their teens had engaged in bullying another child, with the caveats I mentioned earlier, and it was pretty uncommon in teens without autism. And then that third column is looking at teens who had both ever been bullied and engaged in bullying. And you will notice that those numbers are just about as common as ever engaged in bullying alone. And that's because most children who engage in bullying have themselves been bullied. And that's been well described in the literature. And then we see that here. Nearly 90% of teens with autism who parents reported had bullied others had also themselves been bullied, and close to that for teens without autism. Oops, shoot. Sorry, what did I do? Do we have it back?
Your slides are back.
Okay, sorry about that. I just clicked the wrong thing. Okay, so the same kind of analysis, we're taking into account some differences between those teens with autism and without. We still see that they are more likely to have been bullied. Just a little bit more, but more than twice as likely to have engaged in bullying and more than 3 times as likely to have both been bullied and engaged in bullying. So both directions are observed. So just to summarize this part of my presentation, we found that autistic teens were more likely to have experienced recent bullying overall, and particularly verbal, social, and physical bullying, but not cyberbullying. They were also more likely to have ever engaged in bullying behavior, which is not surprising because they were more likely to have been bullied, and the two often go in tandem. And again, they were more likely to have both ever been bullied and ever engaged in bullying themselves. So I thought what I would do for the remainder of my presentation is just talk briefly about some different kinds of evidence-based programs for preventing bullying and violence. And most of these come from the Community Violence Prevention Resource for Action that was produced by the Centers for Disease Control, which compiles summaries about best available evidence for preventing violence for youth and young adults. And some of what this resource guide talks about is really more focused on sort of community violence, like gang-related violence, or criminal violence, but some of it is relevant to bullying as well. So you don't have to be able to read all this. I just wanted to sort of generally show that there's a lot of different kinds of strategies that have been shown to prevent community violence. And some of those are sort of big picture things like strengthening economic security and providing a quality education. And they go all the way down to, at the very bottom, intervening for those, for example, who've already been harmed by violence to reduce the harms that result. I'm going to focus today on examples of 3 types of strategies: promoting healthy family relationships, and I'll talk about some examples of those; strengthening youth's skills, and I'll talk about a few examples of those; and then connecting young people to caring adults and activities. So first, in terms of promoting healthy family relationships, one type of program that has been shown to be effective is parenting skills and family relationships programs. And the way these work is these are programs that are intended to provide caregivers with support and to help them better communicate, problem solve, and monitor and manage their child's behavior. There are across the range of different types of programs like this. Potential outcomes include increasing healthy social development and behavior because of those improving child behavior management skills, and also reducing behavior problems, aggressive behavior, and so forth. So here's a few examples of these types of programs. The Incredible Years targets grade school age children under 13. And it's been shown to improve the good behaviors and reduce the bad ones, reducing disruptive behavior, and also having other effects like improving the connection between the parent and child, improving parenting skills, and actually reducing parent stress. Other programs, Generation PTMO is for 2 to 17-year-olds, and it's parent training. Coping Power is a cognitive behavioral intervention that targets both the child and the parent, and it's specifically targeting teens who already have aggressive behavior problems, preteens and teens. And in general, these types of programs have all shown improvements in social skills, pro-social behaviors, and reductions in aggressive and disruptive behavior. And they also have benefits for the parents, and then other more broadly speaking, some of them have been shown to have benefits for academic performance, for reducing long-term consequences like substance abuse. So these are just 3 examples. There's many types of these programs that have been shown to be effective. So in terms of working to improve the young adults' skills, I thought I would talk about school-based skill building programs. And these are programs within schools that are designed to enhance positive skills, interpersonal skills, and emotional skills. Things like empathy, conflict management, which you could see would be potentially useful for anti-bullying. These programs also tend to give the students information about violence and bullying and opportunities to practice their conflict management, their problem solving, and so forth. And these programs will typically include guidance for teachers on how to support student skills, build a positive school climate. These types of programs have many, many possible benefits, and different programs have different strengths in terms of doing this, but a lot of them have focused on helping improving the general environment of the school, improving the self-control, assertiveness, and so forth of the students, also improving bystander behavior so that they intervene if they see someone who is being bullied. Communication, conflict management, academic behavior, lots of different kinds of benefits from these types of programs have been reported. So again, I thought I would just give a few examples. One that's really well known is promoting alternative thinking strategies, or paths, which is targets elementary school, both general and special education. They have programs. Positive action is school-based, but it also has components that address families and communities, and it's also at the elementary school level. And in fact, the large majority of these school-based skill building programs focus on the elementary school age. And I think that is on the premise that intervening early is likely to be more effective before sort of behaviors that are problems have been cemented. Life skills training is a program that targets a little bit older age, which is middle school. And these school-based skill building programs have been shown to improve positive behaviors like emotional regulation, social skills, and also to reduce aggressive behaviors and conduct problems and fighting within schools. And again, most of them have additional effects beyond child behavior, like academic improvements, and then improving long-term consequences like substance abuse and unsafe driving. And the last type of program I wanted to talk about is programs that are aimed to connect youth to caring adults and activities. And there's several different types of these. There's mentoring programs, which are often one-on-one programs that are pairing a youth with a community volunteer, but there are also school-based sort of group mentoring approaches. And again, the focus is on really helping the youths grow and develop personally, and developing a relationship with a trusted adult so that they have someone to go to if they have questions or problems, while also helping to grow their social skills. And then after school programs, again, give teens opportunities to strengthen their social skills, but also their academic skills. Doing well in school can also reduce aggressive behaviors and disruptive behaviors. And often these also include things like practicing leadership and decision-making. These types of programs can potentially improve academic performance, promote positive relationships, and again, reduce fighting and bullying and violence. So a well-known example of the one-on-one mentoring type program is the Big Brothers Big Sisters of America. And those can be school-based or community-based. And those really involve linking a child or teen with a caring adult volunteer who then meets regularly with them and helps work with them on their academic performance and positive social skills. Becoming a Man is a sort of a school-based group mentoring program. It also has an after-school component. And that one is targeted specifically for boys. Some other types of some after-school programs, examples would be LA's Best, and then After School Matters. After School Matters is interesting because its focus is apprenticeship experiences for high school students, sort of placing them in a kind of a workplace type setting where they have the opportunity to strengthen, again, leadership skills, communication skills, and social skills. And these types of programs, again, have all shown beneficial effects on positive behaviors, self-regulation, and reducing violence and violent crime, gang-involved violence, arrests, physical fighting. And again, all of them have also had beneficial effects on things like academic performance and substance use, drug arrests, and so on. Depends on which outcomes they've actually measured, but you can see that sort of generally all of these programs have had similar kinds of supporting positive skills, reducing negative behaviors, and also enhancing academic performance. So that was just a sort of a whirlwind tour of some of the programs that are out there. And I chose to do this in part because I just wanted everyone to be aware that there's lots of places to intervene to reduce bullying in autistic individuals. It can be at the individual, at the family, at the school, or at the community level. And a good place to start, I think, is this guide because it has information about a lot of different programs and it links you to detailed references. And many of these programs have websites with materials and information that schools or clinicians or others can use, families can use to try to address this. So I'm just going to briefly wrap up to say, so just to summarize our findings, we found autistic teens were more likely to experience a wide range of different types of bullying, as well as to have engaged in bullying. The big problem with bullying victimization is it can exacerbate the existing challenges that some people with autism experience in terms of social interaction and establishing friendships. So those challenges may already exist, and bullying can certainly make it even worse. I think one of the benefits of the school-based programs, rather than focusing only on the individual and their family, is it really builds social skills and promotes pro-social behavior in the entire school population. So that can reduce the bullying by peers and their antisocial behaviors that disproportionately affect autistic teens. And at the same time, it's also helping autistic teens with social challenges to promote their own social skills and pro-social behavior. And that is all I have today. And so I'm going to stop sharing and pass it on to Christy Bartholomew.
Thank you, Dr. DiGiuseppe, and thank you for that overview of bullying and autism. I'm going to talk more about some of the consequences. Dr. DiGiuseppe outlined them briefly, but I'm going to talk more about the mental health consequences of bullying in teens with and without autism. And can everybody see that screen? Let me know if you can't.
Christy, we have the whole, yeah, we have your whole PowerPoint instead of just the slide.
Oh, okay. How's that?
Same.
Sorry, everybody, this was working smoothly earlier. Is that better?
We still have the whole PowerPoint screen.
Mm-hmm.
It was working earlier. I'm not sure why it's not.
Don't worry, it'll come in.
Any better?
The same.
Sorry,
Can
everybody.
I suggest if you can't do it, just pull down the notes and make it bigger and, just shift it around so it fills the screen, even though you've got all the slides there. I think you might need to. Can't get it to work.
I'm gonna try reopening really quickly. I'll just close out PowerPoint and reopen.
Okay.
I think that'll work.
Click on view, that should do it. Click on the view button at the top.
1 minute. Can you still see the PowerPoint? I closed it out.
No.
Okay. Sorry, everybody. All right. Finally there?
It's the same. Do you want
Okay.
me to share it from here, or do you want to try to change your?
Sure. Why don't you share it from there?
Okay, let me open it.
Sorry, everybody. It was working earlier. Thank you. And then if I can, I'm just going to request remote control of your screen so that I can advance the slides. Does that work for
That's
you?
perfect. Yep, that's perfect.
All right, everybody. Apologies for the technical delays there. I'm going to talk, like I mentioned, about some of the specific mental health consequences of bullying in teens with and without autism. And just to note our team, you already met Dr. DiGiuseppe, but we've got a great team here at CU, including Brady, Dr. Schmiggy, and Dr. Race. And then also some collaborators at both the CDC and Johns Hopkins that helped with these analyses. So just a quick overview, I'm going to give some background specifically on the mental health aspects, since Dr. DiGiuseppe did such a great job discussing the bullying aspects, and then the goals of this particular study, the methods that we used, the results, and then like Dr. DiGiuseppe did, talk about some of the actions you can take regarding mental health in teens. So for just a bit of background, this is an overview of what we just heard, but autistic teens are more likely to have experienced recent verbal, social, and physical bullying in this study cohort. Autistic teens were more likely to have ever engaged in bullying behavior themselves, and then they were more likely to have both engaged in bullying and been bullied by somebody else. I think we're stuck. Oh, bullying and mental health. So teens who are bullied just across the board are more likely to have depressive or anxiety symptoms. So those can include things like feeling worthless, feeling lonely, withdrawing from activities that used to bring them joy, or anxiety symptoms, things like intense nervousness, panic, rapid heart rate. But they're also more likely to be diagnosed with depression or anxiety. So meeting that threshold of symptom severity and frequency to get a diagnosis of depression or anxiety. Also more likely to be withdrawn from social interaction with either family or peers or social groups, and more likely to attempt self-harm. Bullying, mental health, and autism altogether, among autistic teens, those who are bullied are more likely to be anxious or depressed, but those who are anxious or depressed are also more likely to be bullied. So you can see how this creates a vicious cycle where people who are already anxious are more likely to be bullied, and then that bullying can lead to anxiety or depression. And so it can kind of become this cycle that's hard to get out of, because the more bullied you are, the more anxious, and then the more anxious, the more bullied. In terms of sex, and I want to just note here, we only have from our study biological sex assigned at birth. We do not have any report of gender identity. So I'm going to use the phrases boys and girls interchangeably with males and females, but just note that we did not have the ability to capture gender identity here. But girls who are bullied may be more likely than the boys who are bullied to think about self-harm and attempt or complete suicide. So in terms of thinking about who is bullied and who is most at risk, it could be that girls may be more likely to have some of these really severe consequences after being bullied than their male counterparts. So with that information, we wanted to look at 3 things here. So the first is, are the teens who were bullied more likely to have mental health consequences? So we looked specifically at anxiety, depression, and self-injurious behavior. And then the second question we wanted to think about is the risk of mental health disorders for teens who are bullied different for autistic teens than non-autistic teens. So originally we looked at just the entire group as a whole, and then looked specifically at whether that differs between autistic teens and non-autistic teens. And then finally, we wanted to look at if the risk for mental health disorders for those who were bullied was different for girls than it was for boys in this cohort. Dr. DiGiuseppe already gave a great introduction to SEED, but just as a reminder, we used SEED 1, so children that were enrolled between 2007 and 2011, and then also completed the SEED Teen Survey, which was done between 2018 and 2021. So we used a little bit of a different cohort for this analysis. We've got actually 3 groups. We've got the group with autism, the group with developmental delays, and a population comparison group. So how these children were recruited is children with autism or developmental delays were identified from clinical and educational records. And for those with autism, they went identified as an autism source. They went through our autism screening and evaluation process. And if that flagged as positive for autism, they went into the autism group. But if it didn't, they were then filtered into this developmental delay group. Same thing for the developmental delay group. They were screened and then either went into the autism group if they screened positive or into the developmental delay group. And this was done to try to make sure we didn't have as many kids as possible that had autism symptoms and a diagnosis ended up in the autism cohort. And then those that weren't were in this other cohort that had other developmental delays or concerns, but not autism. And then a random birth certificate sample, they were also screened and either went into that autism group or into our population comparison group, so POP. This question should look familiar from Dr. DiGiuseppe's presentation. For this analysis, we only used the single question during the past 12 months, has this child been bullied by another child? And if you remember, only parents that had answered the question, has the child ever been bullied, received this question. So we didn't look at types or different aspects of bullying, just the yes or no, whether their child had been bullied in the past 12 months. For the mental health questions, we had kind of 2 categories. The first was a parent reporting that a doctor or other health care provider had ever told them that the child had anxiety, depression, or self-injurious behavior. But then we also wanted to capture things that might not have been an official diagnosis, but that a child was being medicated for. So the second question is, during the past 12 months, has this child taken any prescription medication because of difficulties with anxiety or depression? So a parent could have answered either question 1 with, yes, my child had anxiety, or question 2, they have a prescription medication for anxiety and been counted as that positive for anxiety group. And we did not take into consideration any over-the-counter medications that might be prescribed for anxiety or depression or suggested for anxiety or depression. This only includes prescription medications. So results here, you'll see that this group looks very similar to the one presented in the previous presentation. We had 163 autistic teens, 304 teens with other developmental delays, and 287 teens from that population birth certificate sample. The average age was the same as in the prior presentation, just under 15, and 62% of participants were male in this cohort. This is just looking at the raw percentages of those with mental health disorders among teens who were bullied or not bullied. You can see the kind of gray bar is those who were bullied, and across the board, except for self-injurious behavior, there were more parents that reported each of these conditions than for those who were not bullied. And then that teal bar represents the not bullied. You can also see here that a lot of the mental health disorders that were reported were anxiety. So that any mental health disorder is about 55% and about 50% reported anxiety. So that's by far the most common reported mental health disorder in this cohort here. I will also note, we looked at substance use disorder, and there were very few kids in our entire group, no matter what category they were in, that reported substance use disorder, whether that's because we had a younger cohort and it's not super common at that age range, or because it's not something that parents usually know about. We're not sure. So we looked at it and determined that we couldn't include it because those numbers were so small here. So this is a representation of when we control for other factors like socioeconomic status, classroom type, things like that. This is what the proportions are for mental health disorders among teens who are bullied or not bullied. So this first slide is any mental health disorder. So parents reported any of anxiety, depression, or self-injurious behavior. And the little darker people are those who did have a mental health disorder, and the teal people are those who didn't. So you can see among the bullied, there's about double the number of people reporting mental health disorders compared to those who were not bullied. For anxiety, and remember that anxiety was by far the most commonly reported mental health condition, it's again about double. So in that not bullied category, we're looking at about 25%. And then in the bullied category, more like 50%. So you can see there's a big difference in anxiety between the teens who were bullied and those who were not bullied. And then depression has the most profound difference. Here you can see it's about 20% in the not bullied, and 3 times the number of people who were bullied reported depression. And self-injurious behavior, I will make a note about self-injurious behavior here because it's a common feature of those with autism. So this is heavily influenced by whether a child had autism or not. But you can still see that there's about double the number who were reporting self-injurious behavior among those who were bullied compared to those who were not bullied. Then we wanted to look at the risk of mental health disorders, comparing those who had autism at that initial evaluation back in 2007 and those who did not. And we were a little bit surprised to find it didn't matter. For a child who was bullied, whether they had autism or not, their risk for any of these mental health outcomes, including anxiety, depression, or self-injurious behavior, was about the same. And then we also looked at whether the risk of mental health disorders was different for the girls who were bullied than the boys who were bullied, and we found the same thing. So this is telling us that bullying is really a big part of the driving factor in whether these children have mental health disorders, and it doesn't necessarily matter girl or boy, autistic or not autistic. The key takeaways from this study were that the teens who were bullied were more likely to have mental health disorders, including anxiety, depression, or self-injurious behavior. And then, like I just mentioned, regardless if the teen was autistic or not, bullying increased that risk of mental health disorders. And whether girl or boy, being bullied increased that risk of mental health disorders. So you can see that there's a really strong association here, and that bullying and mental health disorders are closely linked. So that regardless of other features, bullying is something that really needs to be addressed if we want to think about the mental health of these teens and adolescents. Some considerations, and Dr. DiGiuseppe mentioned this earlier. Parent report of bullying may not capture all bullying. They might just not know or not see it, or their child might not let them know. So using this parent report measure, we have to be cautious about over-interpreting, especially if we're not seeing as many people being bullied, because we might be missing a lot of them. And same thing with mental health disorders. If you remember back to that question, the question asked whether a doctor or healthcare provider had ever told them that the child had anxiety or depression, but there could be lots of undiagnosed mental health conditions going on that we're not seeing in the data set. And then this chicken or the egg argument, like I mentioned before, bullying can lead to anxiety and depression, but anxiety and depression can also lead to bullying. So it's hard to understand where in the cycle to intervene. So we want to make sure that we're thinking about this could be both directions in terms of mental health and bullying causing each other or influencing each other. Just want to acknowledge this is the same group of people that Dr. DiGiuseppe presented on earlier, and this all came from the same source, the SEED Study to Explore Early Development, the SEED study, and that was funded from a cooperative agreement with the Centers for Disease Control. And then we always like to acknowledge all of the children and families who participate in SEED, because this research would not be possible without them. Getting into just a few resources for mental health in teens. Dr. DiGiuseppe presented on some resources for bullying, but I want to talk a little bit more about some of the mental health resources. This first part is on how teens can care for their mental health. And this is all about finding a trusted adult. And sometimes teens need a little bit of influence to figure out who that adult should be and who they feel comfortable talking to. So whether you're a teen looking for a trusted adult or an adult wanting to be trusted by a teen, these are some of the tips on how to best find that match. And allowing a teen the space to change and grow and make decisions and even mistakes is one of the major points here. And listening and sharing both the good and the bad. Sometimes parents or professionals have a tendency to, really focus on the good, but letting a teen know that the bad is okay too and it's natural can be really useful in making them trust you and that it's okay to have hard times and okay to talk about those times. And then the point that I really want to highlight here is validating feelings and emotions without judging. This is really helpful in terms of helping somebody be willing to talk. If they feel like they're going to be judged or teased for what they say, then they're less likely to come forward with information that might be concerning. These are some leading questions for how parents can talk about mental health. This doesn't have to be parents. This could be any trusted adult or family member, teacher. And leading questions are very helpful. Can you tell me more about what is happening? How are you feeling? Instead of, are you sad or are you mad? That can be answered with a yes or no. These leading questions can give a little bit more space for a teen or an adolescent to come forward or to share more about their feelings. Do you feel like you want to talk to somebody else about your problem? It's not always the parent that the teen feels most comfortable sharing with. Maybe it's an aunt or a teacher. So asking who they would like to talk to can be really beneficial for teens to feel like there are options. And then the last one, I'm worried about your safety. This is particularly important if you think back to that introduction, where children are more likely to think about or try self-harm. And so letting them know that you're not judging them, but you're worried about safety in terms of how you approach these questions can be really beneficial for teens feeling comfortable coming forward. From the school level, there are different strategies and approaches that can help prevent mental health problems and then also address them once they occur. And one of these is helping students cope with emergencies. So traumatic events, something happened, there's kind of an acute situation, and helping students cope and recognize those feelings during that emergency, but then also following up afterward. And providing a safe and supportive environment. And these can be in person, or there's a lot more virtual environments like this now that can really benefit teens and adolescents. A few examples here for schools are integrating social emotional learning into the curriculum. So you can integrate social emotional learning into any topic, whether it's what you're reading and talking about how the characters might be feeling, or writing, or any topic can integrate social emotional learning, and it can be really beneficial to have that modeled for teens in a safe environment. Supporting staff mental health is also really important. Again, with modeling, this, if the staff feel safe and respected and supported in their mental health, then the students, that trickles down to the students as well. And then reviewing discipline policies to ensure equity, to ensure that students aren't being treated differently based on other characteristics or their mental health status. This graphic describes the multi-tiered system of support in schools. So thinking about it going from universal, this is applied to every student, to targeted, to intensive, that might just be working with one student who has severe concerns. So universal interventions can be school-wide screenings, prevention. Targeted is more connecting with the students that are at risk or that might have had something come up on their previous screening. And then intensive is supporting the highest risk students and providing resources and even clinical referrals for those students. I wanted to share this resource. This is a mental health screening resource in Colorado schools. It's a program that's attempting to get universal screenings in schools for ages grades 6 through 12. And it screens the students across the board for risk of mental health disorders. And then they have interventions, resources, and support that are based on that student's risk, how they scored on that screening. And it also notifies parents and school professionals of students who are high risk within that first 24 hours. So it's kind of casting this broad net to ensure all students' mental health disorders are being addressed if they're there. This link here, and I believe they're going to post these slides. This link here is if you are an educator and you're interested in looking into this mental health screening in your school. There's an interest form, and it's actually due by May 1st this year. So there's a few more weeks to get that in if anybody is interested in that resource. And then thinking about going kind of down that tiers of interventions. So this is a universal school-based cognitive behavioral therapy. This is delivered either in like a classroom or an auditorium setting to all students. It doesn't, separate students with known mental health disorders or not. It's kind of delivered as a blanket to help all students. It has shown to have significant decreases in both anxiety and depression symptoms in students. And this is equally effective if a trained teacher or educator administers it, or if a mental health professional comes in and administers it to the school. The next level would be this more targeted school-based cognitive behavioral therapy, and this would be administered at the individual level to students who have been flagged as having potential concerns for mental health. And this is appropriate for ages 10 through 17. And this type of intervention is most effective when administered by a trained mental health professional. So it can be implemented by school staff like that universal one, but this is actually more effective if you have a mental health professional come in and work with these students. Just in summary, before we wrap up for questions, teens who are bullied are at greater risk for these mental health disorders that I mentioned: anxiety, depression, and self-injurious behavior. School-based screening programs can detect mental health concerns among teens that might be missed just in the classroom setting or by parents. And then mental health intervention, both individually and at the school level, can improve those outcomes. And just at the end here are the resources that I mentioned, if anybody is interested in following up with some of those. And with that, I will open it back up to questions. Thank you all.
Thank you, Christy. While you're unsharing, I'm going to just go all the way to the top of the chat. And unfortunately, I cannot answer that first question. It says, I would be curious to know how many of these bullying instances have resulted in juvenile criminal justice charges. We didn't collect that information. All we have is the question we asked the parents about bullying. I think generally that's probably not very common. And part of that is trying to avoid involving the criminal justice system. There's been lots of issues around equity and how the criminal justice system interventions are implemented in schools and who ends up in the system and who doesn't. And so I think schools lean away from that if possible. And on the other hand, there can be some really serious concerns that are not adequately addressed at the school level. But in this particular study, we didn't gather that information. A parent has shared a resource for parents. That's really great. Thank you very much. It's a resource center here in Colorado, and another person has asked about, how about Nebraska? Don't know about Nebraska, unfortunately, but that's a great suggestion to reach out to this resource center and see if they have colleagues or associates in Nebraska that can help. I was asked, and I went ahead and put a bunch of links in there about where parents can find information. And probably the bottom link is the one that's most generally useful. It's specifically for parents. It's at the Colorado Department of Education, and it's got a whole list of different, of early childhood actually, and it's got a list of different family support programs for parents that you can click on those links, and it includes Incredible Years and Coping Power and a bunch of other programs as well. So that's maybe a useful resource. The next question was for Dina, and she's answered it. Are there any other questions that anyone has for either myself or Ms. Bartholomew? And I'm not sure about the Spanish speakers. I guess Samantha could put that in the chat if they have any questions, maybe. All right. Well, seeing no other questions. Oops, there's a question. So I have to have it in English, though.
Mhm.
I can't hear you, unfortunately. So, it's only allowing you to type in Spanish too. Okay, I don't read Spanish, I'm afraid, so I don't know what your question is, but anyway, does anybody have any questions? I think is what you're probably asking, so yeah. All right. Okay, in the absence of any questions, I will wrap up. Thank you very much to all of you who joined this conversation about this important problem for, actually not for autistic teens, but also for other teens as well, and the important consequences, and that, you know, we all recognize, I think, that we need to address this issue and make sure we ideally prevent it so that we don't have to deal with the consequences. So thank you all very much for participating.